Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry. And I'm your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services, Administration on Intellectual and Developmental Disabilities, and the Florida Developmental Disabilities Council. Tonight is the 6th installment of our 12-part series, occurring every Tuesday night at 6 p.m. Eastern Time through October 9th. Each of the 12 parts of this series is accredited for 1 credit hour of AAFP prescribed credit by the American Academy of Family Physicians. This is recognized by the AMA as equivalent to 1 hour of AMA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org. The archives are accredited for CME credit for the next 2 years. At the end of the webinar tonight, we will give you more information about how to obtain your CME certificate. And for those of you who are not physicians, you may also use this link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. As always, at the end of the presentation tonight, there will be time for questions. So if you have any questions as the presentation is going along, please type them in the question box of your control panel as you think of them. We will try to get through as many questions as possible during the time we have left. So tonight, we will turn our attention to some more clinically relevant topics associated with providing care to this unique patient population. Tonight's webinar is the first of a 2-part presentation on assembling accurate clinical information. The first part of the presentation will be focused on more general considerations, and the second part of the series next week will focus on more specific considerations. Our speaker tonight is a physician from Jacksonville, Florida. Her name is Dr. Linda Edwards. Dr. Edwards is currently an associate professor of medicine and chief of the Division of General Internal Medicine in the Department of Medicine at the University of Florida College of Medicine at Jacksonville. She also serves as the associate chair for the Department of Medicine. She completed her internal medicine training at the Jacksonville Health Education Program in Jacksonville in 1984. And she has been a member of the Division of General Internal Medicine since 1985 and became division chief in 1998. In 2008, she also served on an NIH consensus panel that reviewed the use of hydroxyurea in the treatment of adult patients with sickle cell disease. Dr. Edwards' clinical interests include healthcare transition for youth with special healthcare needs. She is the co-medical director with Dr. David Wood, a UF pediatrician, of JAX-HATS, otherwise known as the Jacksonville Health and Transition Services Unit. JAX-HATS is a primary care medical home for youth with special health care needs. Just as a side note, there is a hurricane going on down in Florida, so if we happen to have a power outage tonight we're in Jacksonville, we might need to make up the presentation at a later time. So everybody keep their fingers crossed, and hopefully we'll have a smooth presentation tonight. So without further ado, I would like to turn the presentation over to Dr. Edwards. Dr. Edwards, are you there?
I am. Thank you, Dr. Holder.
All right, thank you.
Good evening, everyone, and certainly Florida is experiencing the outer bands of the hurricane, so we want to keep the folks in Louisiana and the Gulf Coast in our thoughts, and hopefully everyone will be safe and the hurricane will pass without significant damage to that area. It is certainly a pleasure tonight, and again I thank Dr. Holder for inviting me to speak on this topic. I have to share with the audience that this is not something that I trained for during my residency or medical school, which was quite some time ago. But about 7 years ago, Dr. Wood, whom Dr. Holder mentioned, came to me and said, I want to start a primary care home for patients who are transitioning from their pediatric providers to their adult providers. We submitted a grant request, and we were funded by the Children's Medical Services to initiate this clinic, which is the Jacksonville Health and Transition Services. And it was through this experience that I have develop some on-the-job training in the management of young adults with developmental disabilities. We certainly manage a number of youth who have chronic medical conditions and do not have intellectual disability nor developmental disability, but nonetheless I have had the opportunity to interact with a number of these young people, their caregivers, and most importantly I've learned a great deal from Dr. Wood in my 7 years in this clinic. And so I hope that as we review the information that I have put together for you tonight, that you will find some help when you have an opportunity to include an individual, an adult with developmental disability in your practice, and that you'll find some of the information that I am going to speak with you about tonight helpful in your practice as you begin to see adults with developmental disability. Now, the first thing I'd like to do is just to review with you very quickly the goals. And as you can see here, there are a number of goals. Those that are in teal, I will hopefully cover tonight in the discussion. And if there is something that is not highlighted in teal, that will be something we will discuss in the presentation next week. So what we want to talk about tonight is how to actually assemble information from multiple sources, including the patient themselves, the caretakers that may accompany them, and any residential, occupational, or educational sources that might be available to you. We're going to talk about establishing an etiologic diagnosis, referencing relevant information and resources, and this is critical, and we'll talk about that again more in the discussion. We also want to discuss the importance of performing an annual health and function assessment of the individual with developmental disability, including oral health assessment and screening for specific high-risk conditions and comorbidities that may accompany the adult or the patient who has a developmental disability. And again, oral health is, you will see, come up frequently in the discussion tonight. We're going to talk more specifically about that next week. And then we want to look at appropriately evaluating changes in behavior and adaptive function and how that may clue you in as primary care provider to issues of an acute medical illness. Other goals are to determine what appropriate testing is to do for this a certain patient populations that you may see, common secondary health conditions in this patient population, and then we're going to talk about discussing with the patients and their caregivers themselves the etiology and the progress of the progression of their disease, because it will be important not only for the patient in making plans for their health and their health care, but also for the caregivers who are involved in the assistance of these adults. And then the list seems to go on, but we're going to talk about communicating with the adult with the developmental disability, a simple care plan across the spectrum of cognitive disorders. We will talk about raising the issue and how to respond to issues of sexual and reproductive health, and counseling adults with developmental disabilities about this. And we also want to talk about maximizing health communication skills of patients in order to allow them to be able to communicate more effectively to you about healthcare conditions they may have, either to you or to team members. And then most importantly, as we have in Jack's Hats, a team-based and multidisciplinary approach is critical in managing this patient population. In Jack's Hats, we are fortunate through our grant to have care coordination and transition specialists, and I know that with the financial constraints that many primary care providers have in their offices, this may or may not be as easily accomplished as it is in our situation. Now, first of all, I think it's important that we talk about what are the barriers to caring for the adult with a developmental disability. And I don't think that any of you would find any of these bulleted items as a surprise. I think all of us recognize that as primary care providers, we are providing more care in less time. The reimbursement issues continue to be a challenge, but certainly I think that as we discuss this, there will be some opportunity for you to learn how to manage these patients and break up visits into multiple visits where appropriate, so that it doesn't seem to be overwhelming when you're first introduced to an adult with a developmental disability. Reimbursement issues continue to be a challenge, and a number of adults with developmental disability have federal funding for their insurance, and we know that that can be a challenge. Again, lack of resources. We are fortunate in Jack's Hats to have an RN care coordinator, and we also have a transition specialist and a physician assistant, all whose salaries are funded through the grant. However, if Dr. Wood and I were to rely on our billing, I'm not sure that we would be able to provide the care that we do. But certainly the patient-centered medical home, the use of the chronic care model are methods to improve care coordination. And as our healthcare system evolves, and hopefully there will be funding for care coordination more so in the adult world than there is in currently, and that is seen in the pediatric population, we'll be able to provide better care coordination for the adult with developmental disability. In one study, and actually I provided that for you, and it's provided in the bibliography, the adult providers who felt that their systems of care were good, and the definition of that is not necessarily specific, were able to provide better care. And lastly, there are about 25% of internists that were surveyed, and I realize that this is both a family physician and internal medicine audience, but certainly there was a study that looked at internists and their sense of training, and 25% of internists felt that they were inadequately trained, and they felt that this was a barrier to the management of this patient population. And lastly, as we all know, the number of adult providers for primary care are inadequate in general for the general population, and then identifying an adequate number of providers who would also become trained and educated to manage this patient population is limited. So how do we break down those barriers of improving access? First of all, provider level care is necessary, and hopefully what we are accomplishing tonight and through this series of lectures is providing a framework and some information for primary care providers to better prepare their office practice for the management of this patient population. We know that at the practice level, the way we accommodate adults with developmental disabilities is different, or can be different, from the general population. It's important that the adult with a developmental disability feel comfortable when he or she comes to the doctor's office, that they are greeted appropriately, that the staff recognize that they may have some limitations and that they acknowledge those without making it a big deal. And so practice level care is as important as the physician education, because our practice is the entry point for these patients in many instances. And then system level care, I'm not going to speak about that. I know there are a number of discussions ongoing, but certainly care coordination throughout the system and utilizing resources that are available, and not just within the healthcare system, but the associations that are available to help facilitate the care of the adult with the developmental disability. So how can we improve access? As I said, this webinar is one method to do that, physician education. What I find as an adult provider is that there aren't very many offices that feel that they are comfortable and can accommodate this patient population. We are in the process of coordinating physician education. We have had some CME locally to try and better educate our adult providers and make it seem less daunting to assume the care of these adults into their into their practice. And certainly having a network of specialists is important, and again, bringing the pediatric specialist and the adult specialist together to determine what type of communication is best between those two is helpful when we are transitioning a pediatric age patient into the adult world. And certainly using the subspecialist to help facilitate our patient's care is obviously very, very important. I'm sure many of you are aware that in many institutions there are subspecialty transition programs. Jack's Hats is more unique in that it is a primary care home where we are coordinating the referral to our specialist. Another method, of course, of improving access is care coordination. And as I mentioned, in the pediatric world, care coordination is a provision of care that seems just to happen, and resources are there for that to happen. However, in the adult world, care coordination is not as available as it would we would hope it would be, but certainly with the introduction of the patient-centered medical home and developing these patient-centered medical homes, I hope that we're going to see more care coordination in the adult world. Healthcare summaries are critical. Again, from the pediatric world in the environment that I work, or from an adult subspecialist who is providing communication to the primary care physician. Healthcare summaries, portable healthcare summaries, are critical in providing information to you as the primary care provider as to what would be most beneficial in your management of the patient population. And we've mentioned effective communication with our specialist and subspecialist. We are fortunate here where we have a network of physicians and an electronic medical record which allows us to communicate effectively, and I recognize that that may not always be the case in other practices. And then I think one of the most important things to improve access is to actually define the type of office visits that you will have, particularly with the adult with developmental disability. An initial visit is critical, where data is gathered from multiple sources, as we discussed, whether it be the care coordination through the nursing individuals, or whether it be subspecialty notes. You may have information from other providers. All of this is critical in gathering, and as I mentioned earlier, an initial visit may be a hi, how are you visit in contrast to a thorough evaluation. We also have annual visits and preventive care visits where issues of sexual health can be addressed, where immunizations can be administered where appropriate, where we can look to determine that certain screening studies have been done. And so an annual visit or preventive care visit is very important. And then we have chronic care visits for other medical issues that need chronic management, whether they have hypertension or diabetes or another medical issue that warrants periodic evaluation. And then, of course, we have the acute care visit for the patient population who is requiring assistance for an acute event that has occurred. So just to talk about intellectual disability, developmental disability, the prevalence of intellectual disability in the adult population is 1%, 1.5%. It is critical that we establish and or confirm the diagnosis in this group of individuals. And we're going to talk about why that is important and why genetic testing is important for this patient population if they have not been tested. It is very important in the adult because it will help us understand their behavioral phenotypes and how to manage them. It will help us to anticipate what their health care needs may be, and then it will help with advocacy for them and associating them with other groups that may help to facilitate their community involvement. I wanted to just share here the etiology. Again, about 40 to 50% is genetic, another 15 to 20% is acquired, and then it is this unknown category that is beginning to be reduced because of genetic testing and that is available, that an unknown diagnosis or etiology of the disability is known. So some things I want us to remember as we go through this is that in the adult with developmental disability, intellectual disability, there is an increased prevalence of health problems. So I think we just need to be aware as primary care providers that this is not the general population and that they have an increased prevalence. And then we know that there is, through studies, that there is a disparity in health care that is provided between adults with DD and the general population. As I have prepared for this and read literature, I think, and I don't think, again, this would come to surprise anyone, there is what is termed the healthy survivor effect, where the more severely disabled individual does die younger. Hence, you have healthy survivors that are living into adulthood. However, if you're healthier and you're living longer, this population may be prone to making poor lifestyle choices that can lead to poor health. And so it's important for us to address this with this patient population. And then risks that lead to ill health include the genetics, and so whatever the etiology of their developmental disability is, and then the lifestyle choices that they make, whether it be their nutrition, their exercise, or the medications that we prescribe. And in the adult world, I like to say that when a patient comes to me and they have risks for heart disease, we talk about what they can control, what they have control over, what I can assist them with, and what things we don't have any control over. And as we talk about genetics, we don't really have anything that we can control. However, we can modify our lifestyle, and I can provide medications. And so similarly, we see this in the adult with developmental disability. And I just wanted to review with you the Canadian Consensus Guidelines. Again, this article is provided for you in the bibliography. I think it is very helpful. In 2006, these guidelines were reviewed, they were reviewed in 2011. They were the 2006 guidelines. They were just recently reviewed, and they were revised so that you could have some practical recommendations based on current knowledge and evidence to help manage healthcare issues of adults with a developmental disability. And when we've already talked about the fact that there are disparities between adults with DD and the general population, and subsequently their health is poor, they have increased morbidity and earlier mortality. Again, the etiology of developmental disability should be established where possible. And just to highlight this, in the last month, we have had 2 young men who presented to our office. One most recently who is 18. He had a normal delivery. And at age 2 or 3, he began to show signs of delayed development. And then at the age of 6, he developed seizures. He has graduated from high school with a special diploma, but his family had not had him tested, and it is kind of unclear to me at this point, but we are working through that. When I talked with the mom was concerned that she did not plan to have any more children, and so she wasn't sure that genetic testing was necessary. And as we discussed, I explained to her that we would have the opportunity to identify potentially what the etiology of the developmental disability is in her son, and that it may impact his future health and things that we might want to do to screen and even to treat him. And so we are in the process of referring him to a geneticist. And the second case is a young man who was referred down. He came to see us from Georgia. He had lived with his grandmother who passed away and was with his sister. She shared with me that he had cerebral palsy, and when I walked into the room, he was ambulatory. He was flapping his arms, and he had some signs that suggested to me that this was not cerebral palsy, and so he too has been referred to our geneticist, again to help us determine what the phenotype is that we have here so that we can more appropriately treat this young man. So here are the guidelines. Again, I kind of got off on track there a little bit with the etiology being established. Know that the adult with DD's adaptive functioning can actually improve through the years, or it may decline. And we also want to make sure that we're aware that pain and distress can present atypically. Other general issues are that we need to be frequently looking at medications because multiple or long-term use can result in harm. We don't want to forget that this population, because they are vulnerable adults in many instances, are prone to abuse and neglect. But we certainly want to include the adult with developmental disability in decision making as is appropriate, providing informed consent to them in a manner that they can understand. Again, advanced planning is a must. We are challenged with this in the general population who are healthy in working with them to make decisions about advanced planning, but again, very important for this patient population. And again, we've already mentioned earlier the use of the interdisciplinary healthcare team to best manage the adult with developmental disabilities. So let's get started with regard to what we as primary care providers can do in the management of this patient population when we have an adult with developmental disability who is scheduled to see us. I think most importantly is involve the caregivers early. I can't say this enough or more emphatically. I have learned so much from the caregivers. These are individuals who are with these adults continuously. They recognize changes in their behavior. They know what has worked. They know what has not worked. And heeding their wisdom has been very helpful for me. And also, the caregiver relates well to the adult with developmental disability in most instances. And so they can assist you in obtaining history that you might not otherwise be able to obtain. You want to be flexible and adapt your procedures as appropriate and necessary. You may not be able to get vital signs on an adult with autism or an adult with Fragile X. That may not be an acceptable procedure for them. And so just be aware that we need to be flexible and adaptable when assessing these patients. Also, it's very important to seek input from other healthcare providers, those that have been involved in the patient's care previously, who may be able to provide you some insight. And again, I have used Dr. Wood and his wisdom and insight on a number of occasions. He is a pediatric physician with interest in developmental disability, and he has been a wealth and a resource to me, and again, in my on-the-job training. And so the other is, again, remember that we want to be ethical in our interaction with the patients, with their caregivers, as well as when dialoguing with other healthcare professionals about the adult with DD. And I just want to, again, talking about being flexible and adapting procedures, remember that many of these adults may not tolerate blood draws or injections, and so coordinating this with some other activity or some other procedure where general anesthesia may be administered is certainly appropriate. Also, you want to establish rapport with the client. Remember that in developmental disabilities, in many instances, the adult is being taken out of an environment where they are comfortable, and so the first visit may be very much an uncomfortable situation for them. And so in many instances we use the initial visit as an introduction visit, as a time to get to know the patient and the caregiver, and then bring them back for subsequent visits for physical evaluation as appropriate, or getting additional information. As I mentioned, helping the client or the patient to feel comfortable is most important, and that begins even before the patient ever enters our office, but when our staff is communicating with the caretakers and asking them to bring us information, and what information would be helpful in managing the adult is very important. And we have a great group of medical assistants in our office who relate very well to these adults with developmental disabilities, and know when it is appropriate to touch them or to guide them, and know when taking a vital sign may not be appropriate or be allowed by the patient. And they're very good at working with these patients, and so it's great to have a staff who is willing and flexible. And then you want to explore what the patient's comfort level is with you asking a history and also a physical examination. It is certainly, you want to first ask permission with the adult with developmental disability that you would like to listen to their heart, or you would like to listen to their lungs, or take a look in their ears, and make eye contact with them, get their permission. And in many instances, the caregiver that's with them, if there is a caregiver with them, will acknowledge to you that they are not comfortable with that, and so you can revise your approach to the patient. And also, it's important to know what kind of experience the adult with developmental disability has had in the healthcare system in the past, whether it be negative or positive, because that will assist you in how you approach the adult and make their experience in your system a positive one. So let's talk about the initial assessment. The geneticist evaluation, as I said, is critical. I've already shared with you the importance of geneticists being involved in evaluating. We have a great geneticist here who has assisted us in evaluating a number of our patients who came to us with either a questionable diagnosis or had not been seen. And so when at all possible, get that information if it has previously been done so that you can incorporate that into your file, because that helps you to determine what you're going to be monitoring in the adult. We talked about baseline functional status is critical to determine, and you want to document that. In many instances, the healthcare provider, or excuse me, the caregiver that accompanies the adult will be able to provide that information. You want to know, do they bathe themselves? Are they able to toilet themselves? Do they take their medications independently, or do they need to be supervised? All of this is critical because if there is a change in this functional status, it may be indicative of an acute illness that is ongoing. You want your immunization history. Again, if the adult with developmental disability has been in the public school system, their immunization should be up to date. But don't forget that there are immunizations into adulthood, the influenza vaccine, Gardasil for the appropriate individuals, Menactra. So it is important to determine what immunizations may be warranted for the adult that you're seeing. We've talked about the healthcare summary. One of the things that we do is we actually have an intake form that we forward to the patient and their caretaker and ask them to complete that prior to the initial visit. That includes a transition readiness assessment questionnaire. Again, we're working with emerging adults, and we're inquiring as to their ability to call to make a doctor's appointment. Can they give a history? Can they ask questions? Do they know about their insurance and how to address insurance issues? And they complete that before coming to see us, and then we can use that to prompt questions and additional evaluation. Again, a number of these adults may be in group homes, and the group homes will frequently bring their MAR with them so that you can review the medication list and confirm that what you have is consistent with what they are taking, and then determine whether there's duplication or things that need to be discontinued or changed. And then a number of these adults will have had individualized education plans. Again, if they're in the age group that it might still be in high school and even into their early 20s. And so that information is helpful as well for your initial assessment. Now let's talk about the adult who has an acute problem that presents to your office. Again, I think it is critical that we always initiate the question to the adult. You want to include them. This is their visit. Inability to communicate should not be taken as a lack of an acute issue or concern, and in many instances the adult with developmental disability may communicate in other methods. I actually have a young woman who has cerebral palsy, and she communicates with a sign language that she and her mom have developed. And so I will ask her questions, and she communicates with her mother, and then she lets me know what the issues are. Certainly the questions may need to be redirected to the caretaker if the adult with developmental disability is unable to provide you what you feel is necessary to evaluate them. And as I said, remember, the adult with developmental disability may have an alternative means of expressing their complaint, and that alternative means may be a decline in their functional status. It may mean increased agitation, and so or sleep disorder. So there are other means to express their complaint, and that may come to you as you communicate with the caretaker and issues that they have noticed. And then we're going to talk about the atypical or nonspecific presentation of an illness that may be manifested by a change in the adult's functional status. Other information, you need to confirm that the caretaker that is with the individual is, if they are making decisions with the adult with developmental disability, has legal guardianship and can be involved in their care. Remember that in many instances the legal guardianship may be the parent of the adult who is coming, but if he or she is in a group home, they may be accompanied by a worker at the home and not be able to give permission for certain procedures that you might want to pursue, or so you want to make sure that when you see the patient, if you need to do a procedure, something that requires permission, that you have the legal guardianship appropriately identified so that you can communicate effectively. Living wills, again, I think that we anticipate that we don't need to have these, and I think all of us, whether we have a developmental disability or not, should have the living will. And now we also have already talked about pre-visit questionnaires, but how those types of questionnaires can truly help facilitate the care of the patient, because a lot of the information that you feel is appropriate and pertinent to the care of the patient will be available to you when you see them. I want to just talk a little bit about review of systems. I mean, we all say that we all do this when we're seeing patients, but I think it's important that we do the usual comprehensive review of systems for this patient population, and certainly directing the questions to the adult, and again, asking the caregiver who accompanies them, if that is the case, to assist you as needed. But we want to make sure that we are inquiring about conditions that have increased prevalence in certain conditions, such as dementia or symptoms of thyroid disease in patients with Down syndrome. In patients who have cerebral palsy, have they had bone density testing? Have they had prior fractures? Again, important to know certain issues that arise in certain populations of patients, and how to best cover that in your review of systems. Always want to ask about the level of physical activity. Obviously, a number of our individuals with developmental disability have significant physical disability as well, so physical activity may be limited. Nutrition should always be addressed because, particularly in the patient population of cerebral palsy, a number of these individuals are tube fed, and their nutrition may or may not be as adequate as the adult who is able to feed orally. Some other areas that we want to highlight, again, a patient who has neurodevelopmental issues may have some presentations that may indicate the development of an atypical seizure or a new seizure type. Interestingly, cataracts are seen particularly in the patient with Down syndrome. They're tested as infants, but also you can see that in the adult population, so inquiring about vision is very important. And again, you're going to see some of this repetitively. Hearing issues are important in the patient with developmental disability. A number of these individuals will have dysmorphic facial features. They may have narrowed auditory canals, things that lend to decreased hearing, and then the associated cerumen impaction. So it is important to inquire about these things, and of course included in your physical exam as well. Also, difficulty swallowing or pharyngeal dysphagia is a common problem in a number of the individuals. So it is important to inquire, is there coughing after meals? Is there increase in spasticity if it's a patient with cerebral palsy? What kind of dentition do they have? Do they have any enamel erosion? Again, things that would indicate gastroesophageal reflux. And sleep issues are prominent in the patients with developmental disability as well. Certainly, we have identified a number of individuals in our practice who have sleep apnea. The challenge, of course, is how do you manage this patient population with sleep apnea, because the CPAP machines and other things are very much a challenge for them to use and to wear. Is there any undiagnosed heart disease? Again, a number of the conditions associated with developmental disability, the heart disease has been identified early on and addressed, but certainly remember as the adult ages, and again as we talked about healthcare, or excuse me, lifestyle choices, their lifestyle choices, whether it be the choice to smoke, or whether it is that they do not exercise, they develop obesity and related diabetes, certainly adult acquired health conditions can occur in this patient population as well. Incontinence in someone who has previously been continent may be an indication of a behavior issue, or it may be an issue of an infection, and so those things need to be addressed. Sexual history is very important in the adult with developmental disability. You want to inquire as to in a level that the adult can understand as to whether or not they are engaging or plan to engage in sexual activity. You want to, again, communicate on a level that they can understand, provide information to them about the practice of safe sex, asking questions about whether there is a desire for them to have children, and communicate concerns to them about whether or not their children may have similar disorders, or whether they're even able to have children. So again, these types of conversations are those that can be held during an annual visit or a preventive care visit. It doesn't have to be addressed necessarily during an acute care visit. Again, declining cognition may be an indication of dementia, or it may be an indication of depression. We want to ask, again, in our review of systems about drug use history, and don't forget to inquire about family history of cancer. A number of these adults with developmental disabilities may not know whether there is a family history, but remember that we should be screening appropriately for cancer, and there are some instances where there are greater instances and less incidences of certain cancers. Physical exam, again, we've already touched on this briefly. Recognize that the adult with developmental disability may have individual needs, and they may have capabilities that will necessitate you to modify your approach. Certainly the patient with cerebral palsy and severe spasticity will not be able to get onto the examination table, but that doesn't mean that you shouldn't assist them and their caregiver in getting on the exam table so that you can do a good skin exam, a back exam to assess for scoliosis and any skin breakdown. Importantly is to ensure the patient comfort, the patient is comfortable, and I can tell you that, you know, in some instances when the patient is extremely uncomfortable, we forego the exam. I address this with the caregiver as to what my best thought might be as to what the issue is going on, and we treat based on symptoms and based on what the caregiver is able to provide. But obviously you want to ensure the patient's comfort because you're trying to develop a rapport with the patient, and for future visits that will be important. And in most cases the caregiver is going to stay in the room with the patient, but if you ask if the patient appears to be uncomfortable and they would like the caregiver to leave the room, that can be addressed as well. Again, observation, functional status, how well can the patient get onto the examination table. Interestingly, a number of patients with developmental disability will have low blood pressure, but you also want to, in some instances, if there is evidence or complaints of dizziness or lightheadedness, evaluate for orthostatic blood pressure changes. This patient population also has an increased incidence of fungal infections of the skin and nails, and so you want to make sure that you evaluate for any rash or any dystrophic nails or other changes that might lead to subsequent cellulitis or other infections that might need to be treated. In addition, you want to observe for evidence of trauma. Again, are there falls that are occurring because of a medication, because of an undiagnosed seizure, because of gait disturbances, limb length differences that might be contributing to falls, spasticity. But are there evidence of non-accidental falls as well that can't be explained by a fall? And again, looking back at whether or not there might be potential for abuse or neglect. And then in many instances, adults with developmental disability will self-inflict injury. They may bite the back of their hand, scratching, irritation, and so this may be part of their developmental disability and their disease process, but it may also be an indication that they are in pain or are not able to express what is going on and are trying to get your attention to assist them with this. We've already talked about cerumen impaction. We've done a lot of water wicking of ears in our clinic because of cerumen impaction, and oral hygiene is critical to evaluate, and we're going to talk about that in more detail in the subsequent talk. But dentistry for the adult with DD is a major issue and a major concern. And continuing with the assessment, again, we want to evaluate for evidence of scoliosis and spasticity. And I, in a subsequent slide, have the modified Ashworth scale, which I think you will find useful. You may find in your neurodevelopmental patient with disability that the previous physicians have used the modified Ashworth scale to describe the degree of spasticity. And this is very important because if there is a change in spasticity, again, that may be an indication of an underlying medical need that has not been met. You want to assess their behavior, their mood, their responsiveness to verbal coaching from you or from their caregiver. And then cognitive assessment, I've just mentioned two here, the Down syndrome mental status exam. As you would imagine, doing a mini mental status exam on this patient population may be difficult. So here are a couple of different methods that you can use, and they help the individual recall personal information, orientation to the season, what day of the week it is, and their praxis, and visual spatial function. And so these are important that you want to rely on. This is the modified Ashworth scale that's there for you, looking at degrees of spasticity. And then laboratory and radiographic investigation. These are all adjuncts to your history and your physical, and we all learn that in medical school, that in most instances you should know what's wrong with your patient when you have completed your history and physical. And so it should be an adjunct. However, there may be some early identification of problems that are known to develop in certain conditions, such as thyroid disease in Down syndrome, and institutionalized patients should be screened for hepatitis. Patients with osteoporosis, or excuse me, patients with cerebral palsy, or who are on seizure medications, or who are on Depo-Provera for Menses control, should be screened for osteoporosis. And then, as we talked about, it is important to screen for disease that is seen in the general population, cancers, diabetes, high cholesterol. I think it is important to note that breast and colorectal cancer in adults with developmental disability is similar to the incidence in the general population, and the incidence of cervical cancer is actually less than in the general population. And as we're going to learn in the talk that follows next week, GI tract malignancies actually may be increased in the developmental disability population. Doing echoes and EKGs for screening are not warranted. It is important, however, that there are some, again, for instance, Down syndrome, it may be appropriate to do an echo. Patients with Fragile X may need to be screened for mitral valve prolapse and aortic root dilation. Certainly, if you're going to start a medication that prolongs the QT, you want to obtain a baseline EKG. I just want to run through this briefly with you about recognizing acute illness, and we've already talked about how it's important that the medical history usually leads to the correct diagnosis, but we don't want to remember that some of the drugs that our patients are on may mask symptoms, and again, I think all of you would be aware of this, or withdrawal of drugs may mimic an illness. And so if you have someone who is on immunosuppression, you may mask an infection, whereas if baclofen is withdrawn or an anticholinergic is withdrawn, they may mimic infection. And so it is important to take a drug history. A couple of pearls. Sometimes patients and adjustments of meds for the underlying disease will usually resolve symptoms that are attributable to the underlying disease itself. And so before pursuing a significant diagnostic workup, if you think that the increased spasticity is because they need more baclofen, then you can actually adjust the baclofen and see what the response is. But the dilemma can occur when an acute illness triggers a serious complication of the underlying neurologic disorder. And in a study that reviewed an acute abdomen in patients with spinal cord injury, patients who had perforated ulcers or other intra-abdominal pathology presented with autonomic dysreflexia. They had headache, diaphoresis, diaphoresis and hypertension instead of the typical guarding and rebound. And so the complication of the underlying neurologic disease was triggered by the acute abdomen. And also, symptoms of a de novo unrelated disease may inappropriately be attributed to the chronic disease. For instance, patient with cerebral palsy, acid reflux symptoms, it actually may be a candida esophagitis. So just need to keep these things, keep ourselves alert to these things. And again, unexplained deterioration in functional abilities, decreased mobility, increase in falls, difficulty in performing ADLs, or an increased dependence on their caregiver may all be indications of an acute illness that underlies the chronic neurologic disability. We've talked about spasticity, decrease in strength, dysphagia, dysarthria, and even increased frequency in seizures may be an indication of an acute illness. And then remember that you got that baseline functional status for a reason, because if there's a change in the mental status, if there is a deterioration in an already existing dementia, if irritability or agitation or aggression becomes apparent, then this may be an indication of an acute illness, particularly in the patient population who cannot communicate effectively otherwise. And then the nonspecific signs of blood pressure, sleepiness, incontinence may be an indication as well. I'm going to touch briefly on these syndromes, and I want to say from the outset, I am not an expert in these 5 disease entities, but these are patients that you're likely to see in your office practice if you begin to incorporate adults with developmental disability into your practice. So the Down syndrome patient, the natural progression, again, we talked about how it was important to know what the natural progression of the disease is so that you can communicate that to the patient and the caretaker. It is the most common congenital cause of developmental disability with a birth incidence of 1 in 1,000. I think it is important to know that they do have a decreased lifespan. The average age at death is in the mid-50s, but 25% of patients with Down syndrome will be alive at 65. We need to be aware of screening and treatment for congenital heart disease. That has actually been dramatically improved in survival because of the detection early. But we need to also be aware that as these adults age, that they develop dementia, and we will notice a decline in their ADLs. Again, just want to comment about hypotonia, and again, this is noted in childhood, but certainly as an adult, physical therapy is beneficial as well. And we want to screen for thyroid function. Delayed growth and the average height of about 5 feet may not be able to help us determine who should be screened, and so annual screening, or some would say every 1 to 5 years screening for thyroid disease or any changes that would warrant testing. And screening for celiac disease, if the patient is having GI tract symptoms or the growth has been stunted, you may want to address that as well. These individuals have hearing loss, they've had recurrent otitis, and so hearing tests are appropriate annually, and ophthalmologic evaluations are important in this patient population as well. Early cataracts can develop, and so frequent ophthalmologic evaluations are imperative. Again, another important component, and I think most of you are aware of this, is the atlantoaxial instability. Cervical spine series are likely done when they're younger, but if you're anticipating preoperative evaluation in anticipation of general anesthesia, whether it be for dental cleaning or some other procedure, you want to do cervical spine series to ensure that there is a spinal stability. And then monitoring for thyroid disease, as we have discussed, and many of these adults with Down syndrome are challenged with weight. We're going to talk about dental and periodontal disease again next week, but again, remember premature senescence, remember the development of dementia, and also remember that depression may mimic dementia, and so you want to determine if there are other signs of depression that may warrant treatment, and looking for early decline in functional ADLs is important. And I think this is just a piece of information that tells you that the pediatric physician colleagues manage 3 to 6 children with Down syndrome. It's very much not the case in the adult world, and so the numbers are much less consistent for adult providers. And we want to include the patients with Down syndrome in the decision making about their health where possible. Fragile X, again, is a mutation in the Fragile X mental retardation gene 1, and then there is various protein levels of protein production, and so you have a wide spectrum of disease. Again, it is the most common inherited cause of DD, and it is the most common cause of DD in young men, 1 in 4,000 boys, and not so common in women, but it can occur in young women. But the diagnosis is usually made early on. These individuals have a normal life expectancy. Important to communicate to the family and to the caregivers the life expectancy. Men rarely reproduce, and again, women can reproduce, and so it's important that genetic counseling occur with the young woman as is appropriate. These are some signs that you will see with Fragile X, and you will see this when the adult comes to your office. Difficulty in maintaining eye contact, hyperactivity during the exam. They will frequently have flapping of the hands, and so these are things to look for in the adult. Again, some of the physical features may not become evident until adulthood. Elongated faces, prominent ears. They may have hyperextensible finger joints, large testicles on examination, a high palate. Again, physical findings that it would be unlikely that they would not have the diagnosis at the time you're seeing them, but certainly something to consider. And again, I don't mean to sound like a broken record, but the disease-specific considerations in Fragile X is very similar to many of the conditions with adults with developmental disability. Screen for hearing loss, ophthalmologic evaluation. We've already talked about the echocardiogram. And in men over the age of 50 with Fragile X, we may see the Fragile X tremor ataxia syndrome, where men would develop a tremor, memory, and balance problems as well. And so things to keep in mind as this population ages. Fetal alcohol syndrome, didn't realize it was as prominent as it is, and so these are the faces of young people with fetal alcohol syndrome, and this is evidence of the effects of alcohol on the brain in utero. It is the most common cause of acquired DD, very unfortunate, and so the most severe form is associated with dysmorphic facial features and abnormal brain growth, and you can see the prevalence here is highest among blacks, American Indians, and Alaskan natives. As you can see, the challenges with the patient with fetal alcohol syndrome are cognitive and psychiatric, and so it is very important to include your psychiatric colleagues in the management of not just fetal alcohol syndrome, but patients with developmental disability, to help you discern what is a psychiatric illness and what may be a behavioral problem associated with their underlying condition. And they also need to be screened for hearing and vision issues. Cerebral palsy is a disease that certainly warrants more than the time that I'm going to give to it, but you will see a number of patients with cerebral palsy. They may have pure spasticity and normal cognitive function, or there may be not only spasticity but cognitive issues, and then the individual who actually is fairly ambulatory with cerebral palsy. Again, these individuals, their life expectancy is affected by the degree of spasticity and its impact on their functional level. And again, the higher functioning individuals with CP have an almost normal life expectancy. Shorter life expectancy is predicted by things that would not surprise you, including quadriplegia, poor mobility, and dependent feeding, as well as their level of cognition. You want to manage spasticity because it can be associated with pain, which can worsen spasticity. So it's an ever vicious cycle in many instances. Dental health, constipation is a huge problem in patients with cerebral palsy, and bone health issues because they are immobile, their vitamin D levels may be low, their nutrition may be poor, and then the feeding issues and gastroesophageal reflux. Not uncommon for patients to come to you as an adult and they've already had fundoplication for management of their severe GERD. Here are the management recommendations, again on a brief summary of managing GERD and constipation, dental hygiene, and then assessing for bone health and management of that using our endocrinology colleagues to assist us in using bisphosphonates and other tools for improved bone health. And I think this is a wonderful quote, and it says it all. It says, "I need my primary care physician to interpret my medical concern in the context of my cerebral palsy, neither ignoring that I have CP nor attributing every concern I have to CP." A fantastic message from an individual in Cincinnati. And autism, again, we are seeing a number of patients with autism, which is a social withdrawal that affects association, affect, and ambivalence. And here are the statistics with this. Diagnosis is increasing as we are identifying causes for intellectual disability and developmental disability. You can see the incidence here, and again, the issues are that their health is good in most instances, but social interaction and verbal and nonverbal communication is poor. They, however, may only be able to describe their functional status by increased agitation, self-injury, self-stimulating behaviors such as masturbation, or even regression, again, in their functional status. And so these are all signs that may indicate an illness that we need to look into and address. And these are other issues relative to the patient with autism. They may have seizures. Sleep disorders are prevalent from the disease itself, from the medications that we use to manage the underlying syndrome, GERD, pain, and then the comorbidity of sleep apnea. And lastly, it is important to remember that, again, like I said, I sound like a broken record, but GERD is an issue. In this patient population, GU issues such as enuresis, masturbation can become a challenge. And then they also have the issues of dental hygiene and ENT problems and eye problems. And so I realize that I rushed through that, but I wanted to just cover those things, and they're available to you in the presentation. And I think you see the repetitive nature of issues that adults with developmental disability have, and how we need to make sure that we address those when we are seeing them in our office. And so to conclude with that kind of rapid fire there at the end, we obviously need to remember that individuals with developmental disability are living longer. And again, when many of us were in training years ago, addressing these problems were left to the pediatricians because these adults were not living into adulthood. Healthcare provider education is critical. And I think it's important not only that we are educated through webinars such as this, but going to the literature where there are disease-specific health management and screening recommendations, and remembering that there are certain conditions that are associated with the underlying condition that we want to make sure we don't overlook. We're going to address dental hygiene at the next discussion, and it is a major concern. And then remember to screen as for the general population for this group of individuals, and not overlook general screening as well. And with that, I will slow down and turn it back over to Dr. Holder.
All right, thank you, Dr. Edwards. That was a great presentation, lots of really good information. Since we're a little over time, could you put it on the final slide here for a second? I just want to go over the CME certificate process for anybody who needs to jump off right away, and we'll do little questions after this. So for anybody who needs to get their CME certificate, you can go to this link that's on the screen, bitly.com/PEDD 2012. From there, you just need to sign in if you haven't already registered, or you need to register. And if you are registering for the first time, you should check your spam filter just in case the confirmation email has gotten caught in there and you haven't received it. If you do have any issues signing up, you can just go to www.aadmd.org, hit the contact button, and it will send an email to one of us at the AADMD, and we can help you work through that system. Once you're on the system, you of course can watch the archived version of any of these webinars, and you'll be able to take a survey about the webinars and also to take a quiz. Remember that the passing score necessary to get your certificate is 7 out of 10. And once you pass it, the CME certificate will be displayed on the screen and also emailed to you automatically. Dr. Edwards, I have just a couple of questions that we got during the presentation. The first one was about the Ashworth scale, and they just asked if you could maybe describe the Ashworth scale in greater detail, because that was the first they had heard of it.
Well, my introduction to the Ashworth scale was from Dr. Wood, and I'm going to go back to it if I can find it in the presentation. We use it predominantly, again, in the patients with cerebral palsy, it is used to assess spasticity at the hips, at the ankles, wrist, and knees, remembering that a number of these individuals have actually had tendon releases or other procedures to reduce spasticity. And here is the the Ashworth scale. I brought it back up on the slides. I think it's important. This is kind of like the 1 through 5 neurologic assessment for motor function, because I think it helps physicians effectively communicate to one another the degree of spasticity, so that, again, it can be determined whether there is a change. But I think the critical part is, again, if there is no increase in tone, then of course the Ashworth scale is 0. However, if you notice that there is increased tone, but with gentle pressure, you are able to extend the joint either at the elbow or at the knee or ankle, then that is a 3, again, based on the modified scale. And again, at a 5, you're really talking about contractures, where there is limited, if any, flexion or extension at that joint. And again, I use it as a method of communicating with Dr. Wood if he and I are seeing patients at different times, but also, like I said, it's like the neurology 1 to 5 motor scale, so that you're all on the same page with communicating spasticity.
Okay, thank you. Another question was about osteoporosis, and the question really was, well, you mentioned osteoporosis, and the question was, can some of this be attributed to vitamin D deficiency, and is there a difference in community versus ICF residents when it comes to vitamin D issues? I guess the question is really more about vitamin D.
Right. Well, actually, I think that is an excellent question, and I think, again, not being a pediatrician, but my understanding is that there is an increasing incidence of vitamin D deficiency in our young patients, young people, and actually we're identifying vitamin D deficiencies in the adults as well. But certainly the institutionalized individuals who may or may not be out in the sun having that 10 minutes of sun, or whose diet may not be like the general population, have an increased incidence of vitamin D deficiency, and we are seeing that fairly regularly. And so we test all of in the JAX-HATS clinics, and I think most of us now are, even in our adult population, we are checking for vitamin D and replacing appropriately based on the guidelines. The challenge in this patient population is also do you use bisphosphonates, for instance, in the patient with cerebral palsy who already has the Nissen fundoplication and GERD, or do you use IV reclast or some other medication intravenously, since using something orally may not be a good option. But certainly we identify vitamin D deficiency, and we are seeing it commonly in the institutionalized patient, but we're also seeing it in the community as well.
Yeah, I would agree with that. I think the articles that I've read on vitamin D deficiency have echoed exactly what you said, that it's becoming a greater and greater problem, or certainly being recognized more and more as a problem in people with developmental disabilities, and certainly institutionalized individuals. And I think that it is a factor when it comes to the osteoporosis that we see in much higher incidence in this population.
Yes. Yeah.
Another question, actually this one came from a dental hygienist. I thought it was worth asking, which this was when you were talking about the review of systems, and the question really was, as a dental hygienist in a dental practice, are these review of systems questions still pertinent?
In the dental office. So that's interesting. Wow.
I know, I'm asking a non-dentist here.
Are you throwing me a curveball? No. Actually, certainly, I think asking questions such as gastroesophageal reflux symptoms, which do impact dental hygiene, are important. I think it's important asking about spasticity, because that will affect the ability to evaluate the adult with DD who may or may not be able to cooperate with the dental exam. So I would anticipate that the entire review of systems is not necessary, but certainly a focused review of systems addressing issues that do impact dental hygiene would be appropriate.
Yeah, I agree with you on this too. I think it also depends on the role that the dental office is going to play, because I've seen some dental practices take on more of a medical home approach, and they actually call themselves a dental home. And when they do that, they almost act as a primary care arm, if you will. And so that review of systems becomes more important. For the average dental practice, maybe something more focused. So it probably does depend on the scope of your patients and the scope of your practice, I think. Let's see, another question on celiac disease. I guess the question here was, does celiac disease present differently in people with DD, and is it really more common in developmental disabilities?
Wow. I'm not sure that and I might have to defer to you on that. I think there is my understanding is there's an increased incidence of celiac disease in the patient with Down syndrome, but it may be detected earlier. And not necessarily present in adulthood. I'm not aware that celiac disease can present from iron deficiency anemia to generalized weakness to constipation, and so the presentation of celiac disease is not always a specific presentation. So I would think if you had an adult with DD who had an unexplained anemia, or if they had issues with either diarrhea or constipation, and your workup was unrevealing, that pursuing tissue transglutaminase antibodies and other means of evaluating that would be appropriate. I'm not aware that it has an increased incidence in the developmental disability population, but some specific syndromes it may be increased.
Yeah, I'm kind of drawing a blank on this one too. I think that I know I've certainly heard about it more since I've been in the field of developmental disabilities, so I know that there's certainly more interest in it. I've also heard people talking about it in the autism community too. I would have to look that one up on the incidence there in developmental disabilities, but I do know there's certainly more interest in it in developmental disabilities.
And actually, to add to that, and I think I can address that next week, but one of the articles of reference is in gastrointestinal disorders in the autism spectrum disorders that's attached to the bibliography, and they speak specifically about celiac disease, and that general testing for celiac disease is not warranted, I believe is one of the recommendations from that group. So there may be some additional information in that article specifically about celiac disease.
Okay. And one last question about heart disease, and it was well, it was related to actually patients' ability to participate in sports activities. I guess the question really is, since these are more undiagnosed, does that make a difference in terms of somebody's ability to participate in sports activities?
Wow. Again, another question that, sports medicine, and I just actually, one of our faculty members just did a presentation within the last year about screening for heart disease. Again, this was in the general population, and you're right. So in the developmental disability population, where there may be an increase in, well, certainly there's an increase in congenital heart disease, and whether there is a increase in acquired would be relative likely to lifestyle and family history. I think certainly if you have a patient that is on a medication that prolongs a QT syndrome, that you should look at their EKG and make sure that they don't have prolonged QT interval that might warrant either additional testing or acquiring. Certainly you want to ask family history in that situation, whether or not there is unexplained sudden death, syncope in family members that might tip you off to doing additional testing. And I know that's probably not the best answer, but again, I think the issue of prolonged QT and then knowing whether or not valvular heart disease is part of the syndrome that you're evaluating and how that might contribute to sudden death or something like that would be what my recommendations would be.
Yeah, I think you're right on there. I know that long QT is something that, well, it can be a side effect for a lot of medications that our patients are on. So I don't really know whether long QT whether it's at a greater prevalence in this population or not, but I think certainly given the medications that our patients are on, there's a certain possibility that we could be inducing it with the medications we're putting them on. So certainly that could play a part in that. And I think probably just because, I mean, as you said, they're undiagnosed, so or more likely to be undiagnosed. So if it's a concern, then it's probably worth making sure that you have a good cardiac workup
Yes.
before engaging in high endurance type sports activity. Well, okay, I think that's it for the questions. So I would like to thank all of you for attending tonight's installment of the PEDD webinar series, and I would especially like to thank you, Dr. Edwards, for a great presentation this evening, and we'll be seeing you back next week. Please remember that in order to get your CME certificate, you need to go to the website that was on the screen. If you have any questions or concerns, you can email me at mattholder@aadmd.org. Please join us next Tuesday at 6 p.m. when Dr. Edwards will be returning to present the second part of this two-part presentation on assembling accurate clinical information. I hope you'll join us, and thank you from all of us at the AADMD, and have a good night. Thank you, Dr. Edwards.
Thank you.